Well, good afternoon, everybody. This is Jake Galdino, PQA's Director of Education and Program Development, and we're really excited for today's Quality Forum. We are going to be talking about antimicrobial stewardship, improving quality through optimized antimicrobial use. I'll talk a little bit more about our speaker today, Luke, but we have Lucas Schulz from the University of Wisconsin Health, who'll be joining us and talking about his program and his work in this area. As always, we do have our couple webinar logistics. Luke and I are the only ones that are able to talk. So as you have questions, please submit them through the questions field. So I'll be able to ask those to Luke at the end of the presentation. This is being recorded, and a copy of the slides and audio will be available to PQA members within about a week or so on our members resource page. And as always, when you close out of this webinar, it will have a survey. So please fill out that information and let us know how we can continue to do well. I do want to start with a big thank you to PerformRx. They're an educational sponsor for this quality forum, so thank you, PerformRx. And so we have today's presenter, which is Luke Schulz. He's a doctor of pharmacy and board-certified infectious disease pharmacist. Got to give him a big round of applause for that. I think we're only in our second year of individuals having that designation, so kudos, Luke, for getting that. He's a clinical coordinator in infectious disease and a critical care and infectious disease clinical pharmacist. He's responsible for all anti-infective use across the University of Wisconsin Health enterprise, leading the antimicrobial stewardship program at UW Health, and is involved in all institutional committees pertaining to IB. He's also served as a postgraduate year 2 IB residency director for the past 7 years. He's got a lot of great information to share. As we were getting ready for this, I had so much fun talking to him and learning about his great depth of expertise and excitement in this area. So we're really excited for this. So Luke, thank you so much for joining us.
Well, thank you very much for the opportunity to meet with everybody. I'm excited to talk about antimicrobial stewardship. One, because it's a passion of what I do and part of what I do every day, and I think, you know, and second, it's not COVID-19 to talk about. So I'll try to avoid using coronavirus or COVID-19 for at least the next 40 minutes. But I know it's top of mind for lots of people. So, you know, as we get to questions and things like that, if that's the way the group wants to ask questions, I'm happy to provide some of my insight, or at least perspective on the topic. But let's start talking about antimicrobial stewardship and how to improve quality by optimizing antibiotic use. And you can see the learning objectives today, but really to understand antibiotic resistance and its impact on patient safety, and then how does stewardship improve those patient safety outcomes by optimizing the use of antimicrobials and driving down the impact of antimicrobial resistance. And hopefully by the end, you'll have an idea of what it means to develop a stewardship program, what that entails, and how we can encourage the use of stewardship programs and overall. So it starts with the understanding that the majority of 21st century medical advances rely on antibiotics. When you look at organ transplantation, cancer, chemotherapy, these profoundly make people immunosuppressed. Looking at prosthetic joint replacements, hip, knees, shoulders, these all rely on antibiotic prophylaxis for surgery and then treatment of the risk of prosthetic joint infections. And all of the advances that we've made in surgery have really been supported by antibiotic utilization, either prophylactically or managing the complications post-surgery. And the World Health Organization has identified antibiotic resistance as one of the 10 threats to global health in 2019. And in this next slide, you can see the 10 global threats there. Antimicrobial resistance is listed as number 5. And it's really driving us into a post-antibiotic era. One of the leaders of the CDC has said we're no longer at the doorstep of a post-antibiotic era. We've entered that antibiotic era, that post-antibiotic era, and we are feeling the challenges of antibiotic resistance. So the next slide shows that the impact of antibiotic resistance is not limited to the World Health Organization, but it impacts us locally. It impacts the United States. The CDC puts out a report every year or every few years, I should say, that looks at antibiotic resistance threats. Their most recent one came out in 2019, and some scary numbers come out of that each year, almost 3 million patients are impacted by antibiotic-resistant bacteria and fungi. And this results in almost 36,000 deaths per year. This is in addition to the impact of Clostridium difficile, which is directly related to antibiotic use and antibiotic resistance. And Clostridium difficile causes 223,000 cases per year and 12,000 deaths. Notably, we've made some good strides forward in reducing Clostridium difficile since the 2016 antibiotic resistance report, but the number of antibiotic-resistant bacteria infections and deaths are increasing. So you may ask, how did we get here? We got here through the several factors. Most importantly is a reduction in development of new antibiotics. And what this graph shows is the number of new antibiotic approvals over years. And the graph is broken up into 10-year increments until we get towards the end. And what you see is a stark decrease in the number of new antibiotic approvals starting in the early 1980s. Most of these, even in the 80s and early 90s, were Me Too drugs. They were new cephalosporins, similar mechanisms of action, and most importantly, similar mechanisms of resistance. And this was noted by the ID professional societies that the dwindling antibiotic pipeline was going to lead to a risk of antibiotic resistance catching up, and that we would no longer be able to keep up with the emerging resistance patterns. And this was kind of bolstered and fostered by the fact that manufacturers were leaving the research and development sector, especially big pharma. There's low profitability in antibiotics. Patients receive these for 2 weeks, 3 weeks of antibiotics, compared to a drug that you're going to be taking for the rest of your life. And there was an underappreciation of resistance. For years, we had kept up and were always in front of antibiotic resistance. And the expectation was we had developed enough new antibiotics that we didn't need to stay ahead and keep developing new ones as quickly. So they started to leave the market, and we're entering now a period where antibiotics are resistant, and we're left treating patients without new antibiotics. And this is something we've known about, as I mentioned, and antibiotic resistance has been persistent and evident since we started using antibiotics. I like this graph because it shows the time from discovery to introduction to when resistance is observed. And you look at some of the older drugs, penicillin, tetracycline, erythromycin. We discovered the drug. We had a few years of research, and then it came into clinical utilization. Erythromycin and tetracyclines are good examples of this. Then we had a kind of a honeymoon period where we noted no resistance. But as you see, as we started to develop new drugs, linezolid, dapto, ceftaroline, for example, that period of time from introduction into clinical care to resistance observation is greatly diminished. Some of this is certainly due to improvements in lab detection and monitoring and surveillance for resistance patterns. We know a lot more about resistance and the impact of resistance, so we look for it. But some of this comes simply from the fact that as bacteria become resistant to one or two antibiotics, they're more likely to become resistant to 3 or 4 antibiotics. So resistance tends to pile on and snowball after that. So what causes antibiotic resistance? There's really 3 large buckets that we attribute to causes of antibiotic resistance. One is agricultural overuse of antibiotics. This is being addressed, and is something that is I think many clinicians are aware of. The veterinarians have taken a very aggressive stance on this, and we've pulled back a lot of antibiotic utilization for growth factors. and growth promotion. Veterinarians in Wisconsin, for example, are now required to write prescriptions for all antimicrobials, and we can't just purchase them over the counter anymore. Second is increased transmission. This is really an infection control component. Infection control is very important in preventing the horizontal transmission of antibiotic resistance, especially as patients come in contact with each other or within healthcare systems and in the community. So just general hand washing and good sanitary practices can help reduce that. We're going to focus the rest of the talk on human overuse, and this is really where antibiotic stewardship comes into its place in therapy. So next slide. You may say, well, are antibiotics really being overused? You think of the times when you may go to the clinic or to the hospital and you present to your physician with your symptoms, and they give you an antibiotic and you feel better. And that's a challenging historical context to overcome. So this was a study that was done, and I think is really telling of what ambulatory stewardship, where the need for ambulatory stewardship is, but also it's of great impact to human misuse. About 70% of our antibiotics that are used in the ambulatory setting, so in the outpatient setting. And if you look here, these numbers look at unnecessary antibiotic use in a variety of different settings. And what it found is that antibiotic use was either inappropriate or potentially inappropriate in almost 60% of cases. Most of this comes from respiratory tract infection prescribing. So you go in with a cold or a virus, influenza, for example, and you get prescribed an antibiotic, and we know that antibiotics do not work for viruses. So these were labeled as inappropriate or potentially inappropriate antibiotics. And this is something that is of great importance, because these are antibiotics that are being given to patients, potentially driving antibiotic resistance, changing the microbiome of patients, and ultimately providing no benefit to them. So a target for our utilization. The next slide. And you may ask, does it really matter, right? We have patients who are sick and they need antibiotics. Maybe, one day or one course of antibiotics doesn't make a great difference. And there is a growing number of articles and literature publications that would disagree with that statement. A very impactful one is in the upper left-hand corner, a recent publication in Pharmacotherapy that looked at the use of anti-pseudomonal beta-lactam antibiotics in critically ill patients. So these are patients in the ICU that absolutely need our antibiotics. They're very ill. And looking at the breadth of those antibiotics, are we giving too broad of antibiotics for too long of a period of time? And this study in particular showed that even a single day extra of antibiotics would increase the probability that the organism is resistant or develops resistance. So what this means in practice is if you're giving a patient 10 days of cefepime instead of 7 days, their chance of having a cefepime-resistant Pseudomonas, a bacteria that causes critical illness, your probability of having a cefepime-resistant Pseudomonas was 60%, with just 3 extra days. So we need to make sure that our durations of therapy are appropriate. There's 3 other studies that look at the use of antibiotics when they're not indicated. So antibiotic treatment with patients hospitalized for asthma. These were patients that either received antibiotics versus no antibiotics. The patients that had no antibiotics were hospitalized for 2 extra days compared to the patients who had received no antibiotics. And they had equivalent outcomes. So administering antibiotics provided no benefit and only added cost to the scenario. The adverse outcomes associated with potentially inappropriate antibiotic use, these were patients admitted for heart failure, got IV antibiotics when it was unnecessary or potentially inappropriate. These patients received more sodium and more fluids which we know are contraindicated or contrary to the treatment principles of heart failure exacerbations. We want to dry patients out. We want to limit sodium. These patients received more sodium, more fluids. Patients who received an extra dose of antibiotics for surgical prophylaxis or an extra day of therapy had no better outcomes, the same rate of surgical site infections, and only had increased risk of Clostridium difficile and other adverse reactions. And then we certainly know that each additional day of antibiotics is associated with changes in the microbiome. And the impact of that on patients is unknown, and we're still learning more and more about the microbiome and how that changes patients' outcomes. So it's not fine. We need to make sure that we're addressing inappropriate antibiotic use and trying to minimize unnecessary antibiotic use when possible. So this was the task and the task at hand as we started to enter the early 2000s, and this is how we got to stewardship. This is the brief history of how we got to stewardship. So I mentioned that in the late 1990s and early 2000s, the ID societies were sounding the alarm that we have a dwindling pipeline and an increasing risk of antibiotic resistance. This was heard by the government and the Obama administration in September of 2014, and they put together a council of advisors to address the issue of antibiotic resistance. That group met, created this report. That report resulted in an executive order, and that executive order became a national strategy for combating antibiotic resistance and ultimately a national action plan. And in that action plan, they addressed veterinary use, infection control components, and established that stewardship is important. In 2016, the CDC created a document called the Core Elements of Hospital Antibiotic Stewardship Programs, and then followed that in 2017 with the Core Elements of Outpatient Antibiotic Stewardship Programs. And in these two documents, they outlined core elements. So the next slide shows the inpatient and the hospital core elements. So these are the check marks for do you have these things, and do I have a stewardship program? So the 7 core elements in the hospital are leadership commitment, accountability, drug expertise. You got to take an action, and you have to track and report the impact of those actions and educate people about your stewardship and antibiotic misuse. The ambulatory core elements are very similar. They compacted a few of those, so you'll see that you have commitment from your leaders, and that you have somebody identified as a drug expert or a leader for the stewardship program, and that program takes action for policy and practice. Can we do something to change our practice and our antibiotic prescribing? When you make that change, you need to track and report it. You need to educate back to the providers that it's impacting and use your expertise to pick the next topic or the next opportunity to improve antibiotic utilization. So we were left with that in 2016. The Joint Commission adopted those core elements for hospital stewardship, those 7 components to start measuring and accrediting hospitals too. So when they came to your hospital, you had to show them that you could meet those 7 core elements. Leapfrog and DNV also have adopted similar components to evaluating hospitals and accrediting hospitals for stewardship programs. So, and then just to round out with the most recent component, in 2019, right at the very end, the CDC updated the core elements for hospital antibiotic stewardship programs. They still remain the 7 core elements. They just added a few components to it and actually clarified the role of the drug expert and allowed pharmacists to serve both as the drug expert and as a clinical lead for an inpatient stewardship program. And ultimately, what I think from an ID standpoint, we're most excited about is that CMS has made a final rule which requires stewardship, and that's effective in just a few days now, a few weeks. It becomes effective as March 30th. So any hospital participating in CMS is now mandated to have a stewardship program that will meet those 7 core elements. And Arjun Srinivasan, one of the head of the CDC stewardship task forces, I really like the way he said this, is that stewardship's no longer something that's nice to have, it's now required to have. And I think that's very, very telling. So next slide. So we're at a point now where inpatient stewardship is required, and people always ask, well, what's next? What does the future hold? And I think it's definitely ambulatory stewardship. So we're going to talk about inpatient stewardship and how UW does this, and then how we do ambulatory stewardship and where we're trying to go with that. So next slide. I think a lot of hospitals are left in this place of kind of saying, oh, well, CMS is coming and it's required. What are we doing? Are we ready? Am I ready, or am I not ready? So hopefully the rest of these slides will give us some idea of where we're at and how you can help make your hospital ready for this and improve patient care. So we talked about what antimicrobial stewardship is. The inpatient is on the left, outpatient is on the right, and you can see that there's a lot of similar components to this. So the next slide, the leadership and accountability and drug expertise. We are in a challenging time for this. There are not enough ID trained physicians and pharmacists to lead and be stewards for every hospital. When you look at the number of board certified infectious disease physicians, there's about 8,000. There's 200 new fellows trained per year. For board certified pharmacists, it was great. We had a nice uptake right away, but we are pretty much maxed out with the number of people that are eligible for board certification, and there's only 850 board certified ID pharmacists in ID. And then there's 117 ID training programs, and we graduate about 100 new pharmacists per year. So certainly not enough ID trained people are coming out per year to staff all of the hospitals that we need. We tend to congregate towards academic medical centers, large community hospitals, ones that can support research and the kind of emerging infectious disease complications that ID trained people tend to seek out. So small community hospitals often function without an ID specialist. And we know that if you do have an ID trained physician or pharmacist, that you have an increased likelihood of reporting a successful stewardship program. So the stewardship programs, when they are led by ID trained people, often turn to a few core strategies to implement stewardship. And one of these is prospective audit and feedback. This is one of the actions that's allowed or that accounts and can be counted towards your Joint Commission and CMS accreditation. And I hope to give you an idea of what prospective audit and feedback is. Next slide here. So this is an example of something we have done at UW to try to partner with some of those community hospitals and small critical access hospitals. You can see a map of the state of Wisconsin. Bucky represents the UW hospital. And we have a significant number of critical access hospitals that don't have the ID stewardship or ID trained physicians and pharmacists there to drive antibiotic prescribing in an optimal way. And that's important because we, for a multitude of reasons. One, our goal is to improve the health of citizens of the state of Wisconsin. So we can do that, and we can use all of these hospitals to do that. That's part of our mission and goal of the university hospital. Second, probably most importantly, is that antibiotics and infectious diseases don't just stay at your hospital, right? The antibiotic misuse across the state impacts the types of infections that we see at UW. So there's an impetus and a motive for us to try to want to improve that care. If we can improve antibiotic utilization across the state, we can see improved patient outcomes at our institution as well. So what we did was look at the problem that we have, and that really inappropriate antibiotic utilization doesn't just impact me, but it affects all hospitals and all of our patients. So how can we share some of the UW stewardship practices with community and critical access hospitals across the state? So we implemented a pilot program and a program that we're continuing to expand that we're calling Telestewardship. So next slide. What is Telestewardship and what does it do? We perform prospective audit and feedback every day for our critical access and partner hospitals. From my computer, I'll go out, I will review patients and I'll do chart reviews of them. What antibiotics are they getting? What microbiology tests do they have? Is there an opportunity to improve antibiotic utilization? I'll make a request to the primary team or the pharmacist that's the local pharmacist and say, consider de-escalating antibiotics. And what we see is that when we partnered with a community hospital and targeted broad spectrum antibiotics, so these are carbapenems, vancomycin, piperacillin tazobactam, fluoroquinolones, these types of antibiotics that we want to drive down utilization and make sure that we're only using them in the most appropriate patients. What we see is that when we partnered with them for the Telestewardship program, we significantly reduced their antibiotic days of therapy per 1,000 patient days, which is simply a metric for antibiotic utilization. So we drove down broad spectrum antibiotic utilization, and that is a surrogate for improved patient outcomes. And that's what we saw. Our Telestewardship, when we partnered with them for our pilot period, we saw a reduced length of stay. We saw a reduced 30-day mortality rate. We decreased their total antimicrobial cost and their cost, and subsequently their daily antimicrobial cost and their cost per admission. So multiple benefits. First, to the patients, they were receiving more narrow spectrum, more targeted antibiotics, which reduces their disruption of their microbiome, decreases their risk for adverse drug reactions. We saw a benefit to patients and the system by reducing their length of stay, reducing their mortality rate, and we saw a financial impact also by reducing the total antimicrobial cost. This was a nice study that looked at, we were actually just doing this for a 9-month pilot period, and we stepped away, and Monroe started doing this again. We saw a slight increase in their days of therapy, but it was not as drastic as it was before. So there was some evidence of learning and improved antibiotic prescribing and comfort with being able to provide more narrow spectrum antibiotics. So what do you need to do? What's needed to provide effective prospective audit and feedback? I think there's really 4 things, and all of these things are compatible with the Joint Commission, the CDC core elements, and the CMS requirements. So first, you need to be able to identify patients, and then you need a standard of care to review against, and mechanisms to intervene and optimize therapy, and then to be able to track and report this, your interventions. So on the next slide is just a brief idea of what this looks like for UW. And this applies to how I do stewardship at my hospital as well. So you can see it starts, this is a snapshot of our electronic medical record. And we simply generate a list of all patients on antimicrobials. In the upper left-hand corner, you can see this is a list of all anti-infectives for all patients. On this day that I captured the snapshot, there were 280 patients. Now, after some mergers and acquisitions and using more community hospitals, we're averaging about 320 to 330 patients per day of review. You need this generates a list, and now we have a report that sits right underneath the list. So I highlight a patient, and I'll see that this is a patient that's on vancomycin and piperacillin tazobactam, and then we've generated an antimicrobial score scoring tool that looks at, this is a patient that maybe have received more than one anti-pseudomonal agent. Maybe they have a diminishing creatinine clearance. or this is a patient who's able to take oral therapy. So is this a patient that might be eligible for antibiotic de-escalation, IV to PO changes? Maybe they need a dose adjustment because their serum creatinine has decreased. So these are opportunities to make interventions. And on the next slide, I'll show you that this is how we make our interventions. So that patient who was on vancomycin and piperacillin tazobactam for 3 days, I would review that patient and discuss the case with our medical director and come up with a plan to say, this patient has completed 72 hours of broad spectrum antibiotic therapy. Their microbiology shows no resistant microorganisms. And if the patient's improving, please consider narrowing anti-infective therapy to a drug like ampicillin sulbactam. We provide some education here with these links to literature that support our recommendations, and we sign this. And this is filed as a progress note. It's part of the medical legal record. I sign my name to it. There's communication. My pager's on there. My cell phone's listed on there. So if people have questions, they are free to call. And this triggers what's called a best practice alert. So it pops up a box that says that the stewardship team has left recommendations. Please review those and make changes accordingly. There's a few things that I think are really important with this when it comes to stewardship and developing an effective stewardship program. And first is that we are documenting our recommendations in the medical legal record. I'm willing to go and put my name on the record to say improving antibiotic utilization is important. Our physicians are smart. They know that antibiotic resistance is an important factor. They know that overly broad and suboptimal antibiotic use drives that. This is me going to bat with them to say, I'm comfortable with de-escalation. I know you are, and this provides a lot of comfort to them, saying somebody else is here with me. And it's different than other stewardship programs, which may put in sticky notes, or the old school way of doing it back in the paper charts was we'd write a little Post-it note, put it on the chart, and then when you did it or didn't do it, that note was always able to go away, and that didn't provide a lot of comfort to the primary team when they kind of felt like they might be left out to dry if something bad happened. Second, we've termed this minimally invasive antibiotic stewardship. The use of the best practice alert allows the providers to address this when they're going into the patient's chart. So it's important that when you think about making interventions, when are you making that within the provider's workflow? Many of our interventions go to surgeons. Surgeons may round on their patients very early in the morning. I may review this patient 9 o'clock and want to make an intervention at 10 o'clock. Well, the surgeons in the OR, they may be have their hands in Mr. Smith, and now I'm calling or paging them to say, can you consider antibiotic de-escalation in Miss Jones? They need to remember that when they get out of the OR at 6 o'clock or 7 o'clock or 8 o'clock that night. And oftentimes we would notice that didn't happen. So we were distracting them in the middle of a case or rounds, and they were rounding on somebody different. This is something that just shows up when they go into that patient's chart and they're ready to think about Mrs. Jones and what are my antibiotic plans for Mrs. Jones. So I think those are two really important things: being willing to document the medical legal record and putting your interventions at a time when the prescriber and the physicians are ready to see those. So next is is kind of a step aside and starting to think more about the system that we work in. And I think this is an important new role that stewardship programs are playing a part in. So I mentioned that the antibiotic pipeline was dwindling, and you can see that in 2008 to 2012 we only had 3 new antibiotics approved, and then as I showed you, there's the National Action Plan, and part of that action plan was changes to the medication approval process that made it easier for pharmaceutical companies to bring new antibiotics to market. And we saw a nice response by Big Pharma to do that, with 16 new antibiotics being approved since 2013. Unfortunately, those no longer come at a price tag of a few handfuls of dollars per day. These newer antibiotics are costing up to $1,000 per day. And stewardship really is in a place now to help guide where do these new antibiotics fall into therapy. We can't justify using them on every patient, but how do we identify patients that have risk factors for highly resistant or extremely drug-resistant pathogens? And can we initiate those patients on early appropriate antibiotic therapy and see a benefit in mortality and length of stay by getting patients on early appropriate antibiotic therapy? So that's a little bit about what our stewardship program has done historically. We started our program in 2002, coming up on year 18 of antimicrobial stewardship, and we've done many small projects, big projects that have been aimed at improving patient care. So we've reduced the length of stay, we've reduced ventilator days, we've reduced patient mortality through a variety of different processes that we've undertaken, whether it's improved antibiotic dosing or a strategy to early de-escalate patients that don't need broad spectrum antibiotics. We also have an antimicrobial restriction policy. Our stewardship program, this is what I didn't talk about. I focused mostly on prospective audit and feedback, but restriction is another core component, strategy identified to do stewardship. This requires that a provider call and have a discussion with an ID-trained physician or pharmacist to request the use of some of these novel or end-of-the-line therapies. We don't require it for the use of broad, narrow spectrum therapies, but we do require it for carbapenems or some of these new agents coming out. It's a face-to-face or a phone call that says, this is my patient. I'd like to use a drug like meropenem, for example. Would you approve that? And we've managed to successfully do that for 18 years as well. This is an example that just looks at our use of fluoroquinolones. We recently restricted fluoroquinolones in response to a Clostridium difficile outbreak. And that process of restricting fluoroquinolones, we reduced our use of fluoroquinolones by 80%, and we saw a reduction in our C. diff rates by 85%. Good antibiotic stewardship leads to reduced rates of antibiotic-resistant bacteria. And our program, we've got one of the lowest rates of MRSA in the academic medical centers at 23% for our entire institution, which is very good considering the complexity of patients that we see and the amount of antibiotics that are necessary to use in our patients. So I always like to focus on those three. We want to focus on clinical outcomes for patients in antibiotic resistance, but the easiest thing to measure is certainly cost. And what we've seen over the years, if you plot our budget and our antibiotic utilization compared to an unexpected inflammation or the increase in projected spending, we save about $2 million per year, and we're close to $25 million overall savings since the start of our antimicrobial stewardship program. So we're very happy with our progress that we've made on the inpatient side. So I prefaced this just slightly earlier, but we're looking at the final frontiers of stewardship. Is it inpatient? Probably not. It's probably ambulatory stewardship. And I'll give you a brief highlight of what the things we're working on the ambulatory sphere, trying to be ahead of the curve when it comes to accreditation. So next is just a reminder of the 4 core elements. And really those core elements need to be applied, and the actions that we take need to be applied to two groups of people, one to prescribers and one to patients. So next slide, we're going to talk about what we've done to identify or address prescribers. This is a study that was done that looked, this was in Los Angeles County clinics, and they simply measured what was appropriate antibiotic prescribing. So they did that in the pre-phase, and then they started intervening. And their intervention was simply comparing peers to each other. The top 10% of physicians received an email saying, "Good job, you're a top provider." The bottom 90% said, "You are not a top provider." And what we saw was that the rate of inappropriate antibiotic prescribing decreased significantly when providers were receiving that "you're a top provider, you're not a top provider." And most importantly, and I think most that shows the impact of this, was that once the providers no longer got that email, that notification that they're a top provider, you still see that the rate of inappropriate prescribing remained very low, much lower than the control clinics that were included in this study. So this is an intervention that maintains itself over time, and you do see a slight increase up, but this is something you could implement periodically and drive inappropriate antibiotic prescribing down. So what's that look like here at UW? In the next slide, this is how we started. First, we needed to get good data. So with every antibiotic order, we require that the physician enters an indication. So this would be an example of an antibiotic order, and they're telling me that they're using it for ear, nose, and throat and sinusitis indication. And we implemented this simply to collect good data so that we could provide prescribers good data and reports back. And we saw that viral conditions like acute sinusitis, bronchitis, and upper respiratory tract infections, their rate of prescribing actually decreased by simply asking them the question of what are they using it for. This again speaks to the fact that I think providers do know these are viral infections and we should not be using antibiotics. And something as simple as just asking for accountability goes a long ways. In the next slide, we are now able to compare providers to each other. This is in line, slightly different mechanism than what the LA County group did, but we're able to provide a list to department chairs and ultimately to the providers to say, you are a top provider, listed here in green. You have a very low rate of orders per encounter compared to peers in red that are in that not top provider. So they may have a high rate of prescribing per respiratory tract infection encounter. So in the next slide, we show that we can take that data, go out and educate. This is a project, just a very small pilot that we did looking at just our urgent cares. And we can bring data about your prescribing and educate you that says, these are viral infections or viral conditions. We shouldn't be using antibiotics. And what we saw was, again, in all of the viral conditions, we saw significant decreases in antibiotic prescribing over just a short period of time. So very successful tools and processes to implement to drive antibiotic prescribing down, especially in indications that are generally viral and don't require antibiotics. So the next slide is something we did to change patient perceptions. We asked providers, why are we continually prescribing antibiotics for viral conditions? And oftentimes we got feedback saying, well, patients have an expectation that they're going to get those. So we've put up posters like this in waiting rooms and in the patient care rooms to try to educate patients that the expectation is not to receive antibiotics and that they don't need antibiotics for this indication. So we try to reset their patient expectations. And on the next slide is something else we've started to explore. Patients come to clinic with symptoms and are not feeling well, and we hopefully can provide them something for symptom relief. Patients, the feedback we've gotten from our patient advocates and our patient groups is that, well, I came here, I want something. And historically, that's been an antibiotic. And we're looking at, and this is something that's available at through the Minnesota Department of Health, and the CDC has similar things. They're called viral prescription pads. So you can see, and I apologize, it's a little small in the way that this is being projected, but what this is a prescription pad that says, I'm diagnosing you with acute pharyngitis, and it lasts 3 to 7 days. And here's some things you can do that are non-antibiotics. Here's some Tylenol, ibuprofen, naproxen, nasal lavage to help with congestion. And the patient can take this to their pharmacy and ask the pharmacist for help identifying, these are the things I need. It helps the patient have an understanding of what to expect. Here's the duration of time that I expect to be sick for, and here are some things to manage symptom relief. And they go away with something that's not an antibiotic, that's actually going to help them, as opposed to an antibiotic, which really just I think is more of a psychological intervention. So on the next slide, it's kind of a wrap up. So what really makes a successful stewardship program? And on the next slide is a statement from APIC on stewardship, and I like this statement. I think it has really driven and guided my my program and how we address stewardship. As a steward, we get a nice title. I probably get better hours than I get when I'm in critical care, which is a great benefit. But a pharmacist and the antibiotic steward are all trying to do the exact same thing. The physicians prescribing it are trying to do the exact same thing. We're all trying to get the patient the right drug at the right dose for the right duration for the correct period of time and get it started as early as possible. Everybody's trying to make sure that the patients are getting that, whether we're the steward by name or we're a good clinician. What makes stewardship unique is that my job is to look upstream and identify, how did we get to this point where patients were prescribed suboptimal antibiotics? Is there a system flaw or a process that I can change? Can I build an order set to guide an intern at 2 a.m. To choose the right antibiotics for treatment of pneumonia, and based on what my local susceptibility patterns look like and what my stewardship program is recommending? That may be different from where that intern studied medicine, went to medical school, and learned how to practice. So how do we move upstream to get them to choose the right drug at the right time? How do we make sure that patients are receiving optimal antibiotics? And I always, many stewardship programs measure their effectiveness by the number of interventions that they make. How many times did you recommend de-escalation? How many times did you recommend IV to PO? And my viewpoint on that is that the best stewardship programs make 0 interventions. We need to look upstream to solve prescribing and make sure that patients are getting optimal antibiotics as soon as possible. So on the next slide is kind of just a few points to wrap up that, I think successful stewardship programs are led by ID-trained physicians and pharmacists. The role of the ID training is really to feel comfortable de-escalating therapy and stopping therapy. Any physician can order broad spectrum antibiotics and not miss. It takes somebody who's comfortable with antibiotics and the use of antibiotics to narrow therapy and provide narrow spectrum antibiotics. You need to take action to understand prescribing patterns and change those suboptimal practices. Again, looking upstream. This requires that you're able to track antimicrobial prescribing on various levels, inpatient, outpatient, and report that back to providers in a way they understand and in a way that engages them in the solutions. We sought out ambulatory care providers to understand, well, why were you prescribing antibiotics? Well, it's driven partially by my patients. So how do we educate patients about that? And using that, every opportunity as new data becomes available to show providers what they're prescribing looks like, what's new in the literature, and how do you and what opportunities are there to reduce inappropriate antibiotic utilization. So I don't do this alone. We have a great UW stewardship team that's led by ID physicians and ID pharmacists, and I think most importantly is this line at the bottom that we engage not just ID trained people, but we rely on all of our clinical pharmacists. We rely with our microbiology lab, our surgeons, hospitalists, infection preventionists, and we have support from our executive leadership levels as well. We've got a commitment to optimizing antibiotic and providing the best patient care possible. So you can't do it alone, and I always like to thank my group of colleagues in helping us do this. And the one thing that's not on here that I also have to thank is our information technologists and our meds management team. They help build our electronic medical record to make sure patients are receiving optimal therapy as well. So I think the next slide is just a questions one, and I'm happy to take questions. I thank you for all of your attention and interest in antimicrobial stewardship.
Well, Luke, thank you so much for sharing this information. It's really awesome. It's also kind of scary when you talked about some of the data that 3 more days of some of the cephalosporins causes a 60% increase in drug-resistant pseudomonas. It's really scary when you actually kind of think about it. So thank you for sharing that. We did have some questions come in, so just give me a moment so I can pull them up. So one question, Luke, is talking about measures. And since we are PQA, we really like measures.
I think you might be on mute, Jake.
What? Am I? Can you hear me? I'm going to go with you can't hear me.
Oh, now I can hear you.
Okay, perfect. Good.
Sorry about that.
All right.
That was my headset.
Oh, no worries. Gotcha. I had some colleagues at PQA texting me. They hear me, so that's good. So one of the questions that came in talked about potential measures that are useful and feasible within stewardship programs. And some of those measures that this individual shared with us include like days of therapy over patient days of therapy over days present, healthcare facility days. And you mentioned some of the measures that you track as well. Do you think that these could be developed as quality measures by a measure developer like PQA? Where would they be implemented from like a measurement program perspective? Are there benefits to having standard antimicrobial measures, I guess is the ultimate question.
Yes, there is absolutely a benefit to having standardized measures of stewardship effectiveness. There is a balance of what's feasible and measurable, and what impacts and how to get those to a point where you get to a patient outcome level. So looking at rates of C. diff associated with antibiotic utilization is very challenging because there's it's multifactorial. There's many things that go into driving C. diff rates, and for us to be able to pull out that number and identify that fluoroquinolones impacted the rate of C. diff was very challenging to exclude all of the other things that were going on in the changes we made. So there is a component to an ideal of we should be measuring clinical outcomes associated with antibiotic utilization, but it's very challenging because of the multidisciplinary nature of those outcomes. So we oftentimes step back and look at things that we can directly impact, like days of therapy per 1,000 patient days, costs, because they're easy to measure. And I think it's a place to start, and that looking at ventilator days and hospital length of stay requires discrete study periods and controlled settings to try to measure that. So I think that's challenging to do at a enterprise level or on a continuous level, but it should be the goal to tie antibiotic utilization to patient outcomes.
Perfect, thank you. And I know that I try to end our webinars a little bit before the end of the hour, but I'm going to try to get one more question in there by combining a couple thoughts that a few people did, if you don't mind, Luke.
Perfect.
And so these questions kind of focus on the ambulatory care side and best practices there. So that was one part of the question. The other part is adding the payer into the equation. So at the beginning, when you talked about antimicrobial stewardship in the AmCare setting, you focused in on the prescriber and the patient. So I'm wondering if you could also maybe mention where the payer could fit into that idea of best practices.
Yes, something that we have started to explore, and I think that could be expanded when it comes to payers. We are looking at making ambulatory antibiotic prescribing improvements part of physician reimbursement. So taking our rate of prescribing and saying that if you want to either increase your pot of money, or if you want to maintain your pot of money, you need to demonstrate a reduction in ambulatory prescriptions for this disease or condition by 5% or 10%. And I think there's a role that ambulatory payers can have in that, and saying, do you have an ambulatory stewardship program? Show us data that you're measuring, tracking and reporting your ambulatory prescribing, and that you're taking an action to reduce that, and then did you reduce it? I think there's an opportunities there to tie payment into those to say, look, we're taking steps to improve antibiotic prescribing.
Awesome, thank you so much. So I'm going to restart our webinar, jump over and say thank you again, Luke, for joining us. Thank you to you and your team for the great care that you provide to everyone in Wisconsin. Thank you again to our educational sponsor, Perform RX. And then just as a reminder, we do have our PQA annual meeting coming up. Luke, you'll be happy to know that we did not have a single question on COVID-19.
Thanks, everyone.
We didn't have any. And so we still have our annual meeting scheduled this May. We're still all hands on deck, ready to go. So plan on attending. We will be updating our attendees as time goes by, given the current COVID situation. But we have some amazing general speakers like Miss Camille Schreiber, who is Miss America 2020, to be joining us and telling us about, for her case, she'll be telling us about women in STEM and her role as a woman, as a leader, and as a pharmacy student. So please join us there. But again, Luke, thank you so much for joining us. Everybody, I hope you have a wonderful day, and hopefully we'll see you next month at our next Quality Forum.